Hey all, welcome back to the Real Life Pharmacology podcast. On this episode, I'm going to cover SSRI adverse effects as well as sum up some of the most important things you need to know for practice and for your board exams and pharmacology exam. But before we get to the podcast, be sure to check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher, whether you're out in practice or you're a student trying to learn more about pharmacology. Again, simply an email will get you access to that free 31-page PDF on the top 200 drugs. All right, let's get into the podcast today. SSRIs can cause sexual dysfunction as a class type effect. Generally, the highest risk agents here are paroxetine, probably number one. Sertraline also is up there a little bit. But again, all the SSRIs can contribute to that. In patients that experience this adverse effects, and they're like, no way, I'm not taking another SSRI. It was too problematic, too annoying, too bothersome. Usually the go-to antidepressants to consider are bupropion and mirtazapine, which really avoid or minimize or reduce the serotonergic type pathway, which is theorized to contribute to some of that sexual dysfunction. Okay, so again, sexual dysfunction, definitely something you want to ask about. Not necessarily the most comfortable to ask about, but it can be one of the more common reasons why patients discontinue their SSRI, and they may not wait. They may not want to tell you about it as well. So, really, really important to assess that from a test prep standpoint. Definitely remember bupropion and mirtazapine. Those tend to cause a lower incidence of sexual impairment. So, if we need a medication and we're trying to switch off of an SSRI, those are generally the go-to agents to consider. Next adverse effect is GI adverse effects. Remember, there are serotonin receptors in the GI tract, and SSRIs can contribute to diarrhea, sometimes even nausea, dyspepsia, and the most common agent there to cause diarrhea is sertraline. Definitely a good one to remember. Weight gain, weight loss, more weight gain is associated with paroxetine. Definitely a good one to remember there. Less weight gain, or maybe more weight neutral is a proper way to state it. Fluoxetine tends to be maybe a little bit weight neutral there. Sleeping and sedation type effects. Fluoxetine tends to be a little bit more activating. Paroxetine and fluvoxamine maybe more on the sedative side of things. And again, this can be dose dependent. That's certainly important to remember. So if you've got a baby dose of paroxetine on board compared to high dose of another SSRI, maybe that higher dose is going to cause more sedation, for example. So again, dose is important there as well. SIADH, I did allude to, that is a class effect across the board. I'm not aware of any tendencies of one necessarily causing it worse than the other. But it's important to recognize your patient population. So elderly patients are more at risk for low sodium levels, and that's usually primarily due to the use of other medications, and more specifically, diuretic use, as well as carbamazepine is a kind of a classic example that can contribute to those low sodium levels in SIADH as well. So what are the symptoms of that? Very, very important. If you see somebody, confusion, falls, obviously it can progress as sodium goes further and further down, can contribute to seizures as well. So very, very important if you have somebody admitted to an ED, for example. Obviously a BMP is probably going to be drawn as part of their workup in general, just to make sure electrolytes aren't off. If we see that sodium level is low, you got to recognize that SSRIs can be a potential contributing factor there. in the situation of significant or severe hyponatremia. SSRIs are obviously going to be addressed and likely held, potentially discontinued, and patient's going to be switched to another medication potentially there. All right, one thing I haven't mentioned yet is bleeding risk. All the SSRIs are potentially associated with reduced platelet serotonin activity. And in that situation, there is a potential when we interfere with platelet activity that we're going to put patients at more risk of bleeding. Okay? So now if somebody's on, an SSRI alone and, that's all they're taking, and, I really don't generally worry about the bleeding risk too much. It's usually in our patients, which generally tend to be older and taking many, many more medications, where, we can kind of have this additive type effect. You get a patient that's, let's say they're on sertraline 200 milligrams a day. And, now we're taking ibuprofen, and, now that patient is taking aspirin and clopidogrel for a cardiovascular type situation. So now we're increasing medications that can increase that bleed risk, and SSRIs generally can add to that. Now, again, compare that situation to a 32-year-old female that's taking sertraline 50 milligrams a day for their depression. Am I worried about bleed risk? Generally not in that situation. Now, if they're reporting a ton of bruising, those type of things, yeah, obviously, take it seriously, look at it. Okay, is the SSRI contributing to that? It's an important thing to remember. There is some activity there and some potential, but again, probably not as big a deal in somebody who's a younger patient compared to, an older patient taking high risk bleed medications already. All right, serotonin syndrome I want to touch on as well. Pay attention to a bunch of those drug interactions. MAOIs and drugs with MAOI activity. Linezolid. Triptans have serotonergic activity for headache. Tramadol is another good one there as well. So generally we'll want to avoid combining additive serotonergic agents. That's going to increase the risk of serotonin syndrome. Classic findings on a patient who's presenting with serotonin syndrome. We can have some CNS changes, agitation, confusion. We can have an elevation in body temp, so hyperthermia. We can also have some, cardiovascular things happen, such as, tachycardia, maybe even increased in blood pressure. Those are important things to pay attention to when you see a patient presenting. In general, it's going to be fairly obvious, that a patient is taking, either numerous serotonergic agents or excessively high dosages. Serotonin syndrome itself is not crazy common, but, the more serotonergic activity, drugs with serotonin activity that you add to a patient's regimen or doses escalate, the more and more likely that we're going to run into that type of situation. SSRI discontinuation syndrome, I wanted to mention this. We can definitely have flu-like symptoms, insomnia, nausea. Patients can have some sensory changes, some dizziness and imbalance. They can be hyper-aroused, unable to sleep, those type of things. Those are all potential signs and symptoms of SSRI discontinuation syndrome. And I go back to some of the pharmacokinetics and the half-lives of these agents. And again, paroxetine is probably number one as far as the shortest half-life agent and most likely to cause SSRI discontinuation syndrome when that medication is abruptly stopped. I don't think I mentioned it, but fluoxetine tends to maybe be a little bit more on the shorter side of the half-life spectrum there as well. Some of the others are kind of middle of the road. And then the longest half-life is fluoxetine and potentially the lowest risk for SSRI discontinuation syndrome. CYP interactions, quick summary, strong CYP2D6 inhibitors, fluoxetine and paroxetine. Those are good ones to remember. Classic board exam question I've seen is tamoxifen for breast cancer. It can potentially impair the beneficial effects of tamoxifen. So good ones to remember there, fluoxetine and paroxetine, and CYP2D6 inhibition. Major CYP inhibitor, fluvoxamine, that can definitely be really, really problematic. From a broad medication standpoint, lower interaction potential, sertraline. And then I would probably put escitalopram and citalopram in there as well. But keep in mind, we do have that QTC prolongation risk, which may be a little bit higher with those agents as well, when we combine them with other QTC prolonging agents, such as, antiarrhythmics like amiodarone, quinolone antibiotics, for example. Antipsychotics have QTC prolongation potential there as well. So important to recognize that. Pregnancy and lactation, again, sertraline is probably the agent I see utilized the most in that situation. Paroxetine is probably the one that's most concerning, or has the worst evidence, I guess, if you will, in pregnancy, and it's generally avoided. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, geriatrics, BCMTMS, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exam, and we can absolutely help you prepare to pass as well. Pass rates for these exams are very low. They're in the 50 to 70% range. And so you need some study materials that are specifically tailored to the content outline of these exams. We've created that at meded101.com/store. Go check out all those resources, support the podcast as well, and help prepare to pass your exam. Again, meded101.com/store. All right, let's sum this up. Let's do a quick little rapid fire. Some of the most important things with each agent. So fluoxetine, I remember CYP2D6, long half-life, tends to be a little bit more activating. Sertraline, diarrhea, if you remember squirtraline, that can help you remember that adverse effect, tends to be a little bit more prominent with sertraline. Maybe a little bit safer as far as cardiac safety, QTC prolongation risk. Paroxetine, plenty of negatives with it. Anticholinergic adverse effects, tends to be more weight gain positive, which can generally not be a good thing in most patient populations. And withdrawal may be a little bit more prominent because of that short half-life. Citalopram, QTC prolonging agent, definitely an important thing to remember there. Drug interaction with omeprazole, for example. Escitalopram, generally pretty well tolerated, maybe a little bit of a cousin to citalopram. Pay attention to QTC prolongation risk there. And then fluvoxamine, generally avoided because of the high number of drug interactions. All right, well, that's going to wrap up this podcast episode. Hopefully you found some benefit as far as your test preparations go. If you need more support, test prep materials, clinical education, go check out meded101.com/store. Your financial support there goes directly to help fund this podcast and help me keep it going. So I greatly appreciate that. Also, don't hesitate to look up these drugs individually at reallifepharmacology.com. I've covered all these SSRIs in greater depth on an individual basis, and definitely a no-brainer to go back through that if you're studying, trying to beef up your knowledge on this class of drugs. If you've got comments, suggestions, questions, feel free to reach out to me, mededucation101@gmail.com. You can also connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thanks so much. Take care. Have a great rest of your day.